Hi, I'm Carson Panovec, the Cornea Fellow here at Parker Cornea, and today I want to walk you through a case of a piggyback IOL after cataract surgery. So this patient, she had cataract surgery and just wasn't happy with her vision afterwards. She actually ended up myopic and didn't like it, and so we're going to correct it by putting in a piggyback IOL. We don't have access to an excimer laser at our clinic, and it's also a high expense, so I want to demonstrate how this can be a quick and efficient surgery. So let's get started. So here we're going to make actually 2 paracentesis just to give ourselves more ways to get to the eye, to work in the eye. Anything that's not a standard cataract surgery, that's typically what we'll do. Here we're making a main wound. We're actually going to end up extending it because the lens that we use is a little bit larger. We're going in with some viscoelastic material. You can use yours of your choice. This is likely a kind of combo cohesive and dispersive. And then here we're going to widen that wound. Now, we used to not use viscoelastic as much to try to prevent pressure spikes in the post-op period, but we have a way of trying to deal with that now. So this is the lens going in. Again, it's a large injector. This is a 3-piece silicone lens. And the biggest thing that you want to keep in mind is you're trying to get this into the sulcus. And to help yourself, you really want to get that leading haptic into the sulcus as you inject. And the lens will kind of, by nature, follow. So here, it's nice if you can get the trailing haptic in with the injector. However, in this case, the injector just really wouldn't get a hold of the trailing haptic, didn't want to push it into the eye, so I wasn't going to risk kinking it. So I just came out and decided I could dial this in with a Sinski. So here you'll see we're going to grab a Sinski and we're going to use that. And the motion you want to use is this rotational motion. If you try to just push this directly in or bend the haptic to get it in, you'll either A, not work, or B, it'll bend the haptic. And in that point, it won't stay secure, and you may have a higher risk of something like UGG syndrome. So here, dialing in, really dialing further than initially thought I would, but we get the haptic in, and then we can center the lens. And at this point, the case is pretty much done. All we have to do is try to take out that OVD. And to do that, we're just going to use BSS on a cannula. This way we can flush out most of it, try to remove some of the rest of it by suction, and there will be some left in the eye. However, we give the patient about 2 pills of Diamox to take over the next day, and we've found that we really don't have pressure spikes. Now, it's important to have good follow-up with your patient in the post-op period. Make sure you don't see anything like UGG syndrome, but for patients that have plenty of room in the AC, plenty of room in the sulcus, this is a great way to avoid having to go for something like LASIK that may give them dry eye or maybe more expensive or we don't have access to. I hope this was helpful. Thanks for watching.